కదలలేదేంటి ఏంటి అక్కడికి ఓవర్ యాక్షన్ చేయకు లాక్ కాలేదు ఎక్కడికి వెళ్తున్నావు నువ్వు ఎక్కడ వచ్చారని వచ్చానంటున్నా అదే హెచ్ఏ అని రాయి రాయి
Okay, good afternoon. So for this afternoon, we will have benign and malignant conditions of the breast. Objectives for this lecture would be to review the anatomy of the breast, discuss the etiology, pathologic features of different forms of benign and neoplastic diseases of the breast, to list the benign breast diseases that increase a patient's risk of developing breast cancer and classify these conditions by the degree of risk, outline risk factors predisposing to breast cancer and incidence and prevalence of breast cancer, classify it into histologic subtypes, and describe the pathologic feature of each, and prognosticate. Okay, this is just a review of the anatomy. Know the borders. So it's the bony borders would be your clavicle, the sternum. You have your parts, which is the areola, the nipple, fibrous tissue, surrounded by your chest muscles, surrounded by your lymph nodes, and the like. Okay. Medically, so important would be your lymph nodes, your fatty tissue, your mammary glands, and the like. Okay, so this is just a review. Okay. Important in anatomy would be the 4 quadrants of the breast. And it's important to note that majority of your cancers would develop in your outer quadrant. This is mainly because of a large amount of glandular tissue that's found in the upper outer quadrant. So your axillary tail is also found here, extending into the axilla, which gives you more glandular tissue to have abnormalities. So upper outer quadrant, you will find most of cancer developing in the breast. So this would be where your usual breast diseases, both benign and malignant, would commonly grow up. Some would be at the ducts, some would be at the lobules, some would be on fat and necrotic tissue, and the like. Okay. Or there are non-palpable abnormalities that can be seen. And of course, in any mass, the only reliable or definite tissue diagnosis or your biopsy. Okay. So we will first tackle as for the breast disorders, benign breast disease that is not cancerous. Okay. One of the more common diseases that we will encounter would be acute mastitis. Clinically, this is the most important form. Okay. So it's usually caused by bacteria and common in your postpartum lactating woman. More often, new mothers breastfeeding for 3 months. Most common organism would be your staph aureus. And this would appear as cracks and fissures in the nipples and is commonly unilateral. Acute mastitis. Have your postpartum breast with your inflammation. What's the cause? Of our infant would have staph in the nasopharynx, and your infection ascends from a cracked nipple or a plug at the orifice of a duct. We've just blocked by your epithelial debris, leading, and once it reaches the ampulla, will clot and the flying within the duct, thereby causing your inflammatory response. Okay, this is how it will ultrasound. So you will see your fluid accumulating in your ducts through the needle. Ultrasound, it can detect where your abscess is located, can either be sub-Q, subareolar, intralocular. Course management therapy. Breast pump is encouraged to promote milk drainage. Support of painkillers to relieve the pains recommended. So establish breast access. We do recurrent aspiration. We do incision and drainage. So we will have duct ectasia and periductal mastitis. So this is brought about by your dilatation and shortening of the breast duct. So it's a common involutional change that appears around menopause. So compared to a postpartum lactating patient, you have a menopausal women as your patient for duct ectasia and periductal mastitis. So it's associated with an inflammatory process around the dilated ducts. And the biggest risk factor of the introduction and obstruction of the famous debris. Okay. Because of changes as you approach menopause in the hormonal change, you have your dilation ducts. So it becomes filled with stagnant brown or green secretions that will lead to nipple discharge. And this will irritate the surrounding, to inflame and lead to periductal mastitis and abscess. Okay? This causes your fibrosis, which presents as a chronic insulated mass beneath the areola and may mimic carcinoma. So this condition, duct ectasia and periductal mastitis, if you're not careful, will you will have to consider carcinoma. Okay. History, think of cheesy nipple discharge that may arise from one or multiple ducts. Okay. Slit-like nipple mass that is painful, mass with redness, inflamed tissue, the nipple retraction, eczema to skin, and on palpation, you will see the mass, which is an abscess, and more nipple discharge can be expressed during hard palpation. Okay. For duct ectasia and periductal mastitis, investigation. Ultrasound also plays a role, and what you will see would be a multiple tubular structure arising from the nipples. Okay, mammogram, this is to exclude the malignancies. As we have mentioned, you have to consider malignancy in these cases. You do a biopsy for histological investigation and also for exclusion of malignancy. Management is also antibiotics therapy or excision of all the involved major. This is Hadfield. This is the process. So you dissect the plane, you divide the ducts, and remove a wedge of tissue and include whatever fistulous tracts with all granulation with it, and then you close it with a 4O. Okay. Another benign condition would be fat necrosis. So, relatively uncommon compared to the two other previous lesions and would be usually resulting from a history of trauma, prior cervical intervention or radiation therapy, characterized by a central focus of necrotic fat cells with lipid-laden macrophages and neutrophils. So you have chronic inflammation with lymphs and multinucleated giant cells. So this is also can be confused with carcinoma due to fibrosis, mass calcium deposits seen on mammography. Another condition would be your non-proliferative fibrocystic change. So most common, breast disorder. So if you see most common, it has to be a must know. You will see the other most commons in the latter slides. This is commonly called fibroadenosis and no associated risk of progression of cancer. So more than half develop fibroadenosis in women 20 to 40 years of age with no symptoms and presentations. Your pathologic features would be cystic change, apocrine metaplasia, adenosis, and fibrosis. These fibroadenosis can be further classified into two types. You have your fibrosis, which is your fibrous tissue that's similar to scar tissue, and it will feel firm, rubbery, or hard to touch. It could also be cystic, which would be your fluid-filled sacs. Smallest cysts are harder to feel, but they may get bigger anytime. A fibrocystic breast, how do you examine? So we do mammography. So these are for women older than 40 years of age. You will see in the latter slides recommendations when you need to screen. Ultrasound for women below 40 years of age, MRI, and breast biopsy. Okay. Most women with fibrocystic breast will not need treatment. Okay. You may remove the fluid to relieve symptoms. You may give pain meds over the counter to relieve the pain. For severe symptoms, you could give your bromocriptine or your pills to control the hormonal changes. And there are no adverse side effects to this condition and commonly subsides after menopause. So possible complications arises through the fact that cancerous tumors may be more difficult to detect in women with fibrocystic changes. Then you have your proliferative disease without atypia. This is your epithelial hyperplasia. So there's an increased number of layers of cells lining the ducts and the acini. Ducts are filled with overlapping proliferating cells. Without atypia, proliferative disease without atypia, you have your sclerosing adenosis. So this is characterized by an increased number of acini and stromal fibrosis within the lobules. Okay, can be associated with calcifications, which may be detected on mammography. So when you see calcifications, you have to rule out a malignant condition always. So sclerosing adenosis would have risk for malignancy. Then you have atypical hyperplasia. So this is epithelial hyperplasia, which is characterized by atypical architectural and cytologic features. So this can either affect ducts or the lobules. So resemble, but not quite, cancer. There's no diagnostic, clinical, or radiological features that could diagnose atypical hyperplasia. So there's increased incidence with increased use of screening, mammography, and increased number of breast biopsies since we do our investigations quite early. Okay. So those are your benign breast diseases. Okay. Now we go to benign tumors. And the most common benign tumor would be your fibroadenoma. See, this is a circumscribed lesion composed of both proliferating glandular and stromal glands. So usually these are patients less than 30 years old. And patients' presentation is that of a breast mice or a mobile lump. Giant forms can also occur but are more rare, especially in young patients. And we can be associated with proliferative changes in the adjacent breast tissue. Okay? 20% are complex fibroadenomas. So there are two types. If it's more fibrotic, it's classified as your pericanalicular. If it's less fibrotic, it's intracanalicular. And it could be a giant fibroadenoma if it is enlarged or giant in size. Okay, this is usually an uncommon variant, this giant fibroadenoma. And it's characterized by rapid growth. Peak incidence would occur in late adolescence. And usually for you to consider it as a giant fibroadenoma, it's a 5 centimeter mass, but is encapsulated and benign. So the underlying mass may cause a major distortion in the breast contour, thereby causing anxiety in your patient. Okay. How do we investigate? Above 35, it may appear as an oval or round soft tissue density with smooth or lobulated margins. So they usually have very well-defined borders and may exhibit the halo sign. So this is a thin, dark border seen under the edge of the mass. Okay? There's microcalcification seen on mammogram. So this is your popcorn appearance. So it will not require excision unless you're suspicious of the cytology. It is large, very large, or the patient wants the lump to be removed. So it could be either a lumpectomy, cryo, or ultrasound guided. Okay, what is lumpectomy? So it is also called an excisional biopsy, and it's the most common cause to remove your benign tumors. So your periareolar or submammary incision is preferred. Okay. You could do it under local anesthesia. You incise it until you see the capsule of the mass, and then you inoculate. Okay? So the specimen is sent for histological examination. Cryoablation, a small needle is placed in the tumor center under ultrasound guidance. So the tip of the needle is freezed and thus ice crystal is formed inside the lung, which can be seen on ultrasound. So studies have shown there's 92% reduction in the tumor size, and this procedure can be done on an outpatient basis. Okay. Next would be your duct papilloma. So this is a benign papillary epithelial tumor which occurs mainly in large ducts. So papillae are fibrovascular stalks lined by layers of proliferating epithelial and myoepithelial cells. So most patients present with a serous or bloody nipple discharge. You remember your cheesy nipple discharge? What condition is that? What condition gives your cheesy nipple discharge? Anyone?
Yes, doctor.
What gives off your cheesy nipple discharge?
Breast cancer.
We've just discussed it. What's a cheesy nipple discharge?
Doctor Galactoria.
Periductal ectasia. Remember, your bloody nipple discharge is associated with a duct papilloma. Okay? A special tumor would be your phyllodes. So this is also known as your cystosarcoma phylloides or Brody's tumor. So it's not a sarcoma, but may recur locally after simple excision. Usual behavior, it does not metastasize, and it is present in middle-aged female. Can only be distinguished on histology, and your overlying skin may undergo necrosis. Okay. So you have the characteristics of your phylloides versus your fibroadenoma in a table. So it's differentiated according to age, duration, recurrence, size, mammogram findings, ultrasound findings. So distinguishing features as you look at the histopathologic slides, and these would be the initial workup. Okay. And of course, you always look at your core needle biopsy so that you have your histologic diagnosis. Okay. So according to WHO, according to a different classification, it could be a benign phyllodes, a borderline phyllodes, and a malignant phyllodes tumor, depending on the characteristics. If it's metastatic or no metastasis, you would have your management to re-excise with wide margins without axillary staging. Okay. For these benign breast lesions, would have different relative risk for it to progress into invasive breast cancer. So the following conditions would have no increased risk compared to the general population. This would be your mastitis, fat necrosis, mammary duct ectasia, non-proliferative fibrocystic disease, and simple fibroadenoma. A slightly increased risk, which is approximately 1.5 to 2 times, would be your moderate florid hyperplasia, sclerosing adenosis, complex fibroadenoma, and duct papilloma. Of course, moderately increased risk would include your hyperplasias, both ductal and lobular. The breast. Epidemiology of disease shows that it's one of the most common diagnosed cancer in women, which accounts for 50 to 50 decline. As shown in this, as shown in this table in front of you. So, but we have of developing breast cancer. So, gender, being female, of course. Age, years for your premenopausal, 50 years for your postmenopausal. Any history of neoplastic disease of the breast, prior history, present, any family history, especially if it's a sister or a first degree carrier of a BRCA1 or a BRCA2 gene or HER2 gene. And any previous when some reproductive increased estrogen and post estrogen, you're fat, you have you have late menarche, no pregnancy, etc. Those are risk factors for breast cancer. Breast density, lifestyle. Okay, so this is the once this cell proliferates, inactivates your DNA repair, able to correct oneself. And if your proto-oncogene creates an oncogene mutation and activated several more genes, and thereby the cycle repeats. Okay, these are the different histological classifications of your carcinoma in situ, which is your ductal and lobular CIS, and your different types of your invasive carcinoma. Prevalence, most common would be your intraductal carcinoma, followed by your ductal carcinoma in situ, compared to incentives. Okay. 30 incidence would in increased incidence because of the increased use of mammographic screening and early cancer detection. So this will comprise 50% of your screen detected cancers. This is characterized by malignant cells within ducts that do not reach the basement membrane. So there are different patterns. You have your comedo, you have your cribriform, you have your papillary, you have your solid masses. So there are different grades. You have low, you have intermediate, and you have your high. And it's often multifocal and malignant population following, especially in the same breast. For lobular carcinoma in situ, is relatively uncommon. So this is malignant proliferation of small, uniform epithelial cells within the lobules. So there's also a marked increased relative risk for invasive cancer, which is 8 to 10 times in either breast. So for your invasive ductal carcinoma, you have your most common form of breast cancer, especially in poorer populations. So there's increased incidence of screen-detected cancer in developed countries. This is usually a smaller, much better prognosis. Clinical presentation of your IDS. So it's a hard, irregular lump. Pimple discharge or dimpling of the skin would be evident in your peau d'orange, or ulceration or inflammation due to intraductal spread to the nipple. So that's your Paget's disease of the nipple. How does it present? There's tethering of the skin, there's nipple retraction, there's axillary mass, and your metastasis is to the lung, brain, and bone, invasive ductal carcinoma. There are different histologic types. Most common is your serous. Okay? And these would show infiltrating clusters of malignant cells in a dense fibrous stroma. Okay? Other special types would be your mucinous, your papillary, etc. Okay. Comparing it to your invasive lobular carcinoma, it's less common than your IDC, but presents with similar features, difference of which it's more likely to be bilateral and more likely to be multicentric. The histology would be small, uniform cells arranged as strands and columns within a fibrostroma. So this is your Indian file around your uninvolved duct. So these would be your bullseye pattern. So if your IDC metastasizes to the lung, brain, and bone, your interlobular carcinoma metastasizes to your CSF, your serosal surfaces, and pelvic organs. Okay. So for classification, we have your invasive and non-invasive conditions. So invasive lobular carcinoma compared to your invasive ductal carcinoma compared to your ductal carcinoma in situs and your ductular lobular carcinoma in situ. Okay. As for history taking, these are the things that are important to note. You look at the age, you look at the lump in breast, painful or if it's painful or painless, if there are breast or axillary changes, nipple retraction or discharge, there's history of irradiation or malignancy, you have your marital status and menstrual history and family history. So all would point to possible risk factors that could be seen in the patient. Symptomatology. So look for onset, duration, intermittence of pain or discomfort. Is it associated with menses? Character of pain, any other associated symptoms and other factors contributory. Okay, if it's a lump, you look at the duration, consistency, change in size, location, shape, consistency of the lump and mobility, association with menses, tenderness, and the like. Okay. As I mentioned, nipple discharge would be buzzwords for different conditions. Okay? And they are the following. Yellowish, of course, that's a breast mass. If it's serous, it would be duct ectasia or fibrocystic change. Bloody discharge, think duct papilloma or any carcinoma. Milky, if it's galactosile. Cheesy, if it's duct ectasia. Of course, other constitutional symptoms, look at malignancy. Okay. For inspection, so you look at the breast shape, edema, any lump or fungation. Look for any retractions, erythema, ulceration, nipple retraction, erythema, ulceration, or discharge. Okay. So for your physical examination, so you have the arms by the side, arms at the waist position, up in the air, arms extended forward in a sitting position, and your semi-recumbent position. So These are the positions for breast examination, how you palpate. So you have learned most of this in your second year history taking and your surgery physical examination. How do you palpate and what to note of in case there is breast lump. Okay, we just review. So signs of the metastasis, you look at the skeleton, you look at the lungs, you look at the liver, you look at the skin and the brain. So what can you do to prevent breast cancer? Breast cancer screening is important. Breast self-exam or your clinician breast exam, ultrasound or mammography or an MRI. Okay, if you have high risk, you could do risk reduction surgery. So you could do a prophylactic mastectomy. So this reduces risk for more than 90% for women who have a high risk of getting your breast carcinoma. Think Angelina Jolie. Okay? You can also do prophylactic salpingo-oophorectomy. So this reduces the risk of both ovarian and breast carcinoma in BRCA carriers. Okay, mammography. So detect cancer at an early age before it is even physically evident. Okay? So high risk women below the age of 40 years may be considered. Okay. Value of mammographic screening should be explained. Okay. So as in patients with postmenopausal HRT, we would screen prior starting your therapy so that you will have a baseline. And you do your annual or biennial screening every year or by every 2 years for people who've been using HRT for more than 5 years. Okay. So for high resolution ultrasound, it's a first diagnostic imaging method in women less than 35 years for symptomatic women. So in screening mammography, ultrasound is a useful adjunct and is recommended in the assessment of a patient with dense parenchymal pattern on mammograms. So it is most useful in differentiating cysts from solid masses, thereby avoiding unnecessary biopsies. Okay. So mammography, what would be the role? Okay. Screening. Okay. You have your breast self-examination. So you know your body the best. So you have your monthly exam of the breast and underarm area so that you discover changes early. And you begin at age 20 and you do it monthly. So when to do it for menstruating women, 5 to 7 days after the beginning of their period. For menopausal, so that you don't forget same date each month. Also for others, pregnant women, just takes about 10 minutes as long as you do it at least once a month and examine all the breast tissue. Okay, this is what I'm telling you, screening for the general population. So for the general population, every 2 years, 50 to 74 mammography. So for low and intermediate risk women, age 40 to 49, it's not recommended routinely. Okay? 40 to 49, you cannot deny mammography if they want. And BSE is recommended for raising awareness among women at risk rather than as a screening method. Okay. For high risk, so at 30 years, you do your MRI and your mammography, okay, because it's more effective that way. So MRI screening should not be performed in patients with lobular carcinoma in situ and atypical hyperplasia. Of course, your diagnosis would be biopsy. Other tests of importance would be your progesterone receptor, your estrogen receptor, and your HER2 factor. Staging would be as such. It would be dependent on your tumor size. It would be dependent on your lymph nodes. It would be dependent on if there's distant metastasis or not. When you do ultrasound, you will get a Byron's assessment categories. A 0 means it's inconclusive and you need additional testing. Okay, anything 1, 2, 3, benign, you just observe. 4, 5, 6 warrants a biopsy at least. Okay? Just peruse the table more closely. And for management, surgery is the mainstay of treatment for early breast CA and consists of either breast conserving surgery or mastectomy and assessing your lymph nodes. So if it's breast conserving, you just remove the cancer and leave as many normal breast tissue as possible. So some surrounding healthy tissue and lymph nodes are usually also removed. So breast conserving surgery is sometimes called lumpectomy, quadrantectomy, partial mastectomy, or segmental mastectomy. So it's often an option for women with early stage cancer and allows her to keep most of her breast. Okay. So some contraindications, ratio of the size of the tumor will leave unacceptable cosmesis, presence of multifocal or multicentric disease, you don't conserve, or local radiotherapy is contraindicated such that you cannot leave some parts of the breast behind. Okay? So you do your lymph node dissection as you remove 1, 2, or 3 level lymph nodes relative to the pectoralis minor muscle. Typically, you'd get 10 to 15 lymph nodes and at least one section from each assessed by standard hemotixilin and EUS. So these are indications for your axillary surgery. So if your tumor is more than 3 centimeters, women with multicentric multifocal tumors, clinically positive nodes, pregnant or breastfeeding, known allergies, women with previously treated breast cancer. Sentinel node biopsy should not be carried in women with clinically involved nodes. Okay? Safety and efficacy of sentinel node biopsy for breast cancer more than 3 cm is not demonstrated in RCTs. So this is not recommended for these groups. Okay? So these are examples. Okay. So simple or total mastectomy, you remove the entire breast. No lymph node involved, no muscles removed. So simple mastectomy is appropriate for women with multiple or large areas of ductal carcinoma in situ and for women with prophylactic mastectomies. Okay, next would be your modified radical mastectomy. What's added is there's lymph node involvement, which levels 1 and 2 of underarm lymph nodes are removed. No muscles are removed from beneath dress. Okay, so if your cancer is invasive, you do your modified radical mastectomy. So that you could examine the lymph nodes and whether cancer cells may have spread beyond the breast. And lastly, you have your most extensive, which is your radical mastectomy. You are also removing the chest wall muscles under the breast. So this would be cancer that has already spread to the chest muscles under the breast. Although this is common in the past, now it's rarely performed because MRM has proven to be just as effective and less disfiguring to your patient. You also have your partial mastectomy and your nipple sparing. So partial, you just remove the cancerous part and some normal tissue. Nipple sparing, breast tissue is removed, but the nipple is left alone. So these are the boundaries of your mastectomy: clavicle superiorly, inframammary fold inferiorly, sternum medially, and your lateral boundary would be your latissimus dorsi. So you could do breast reconstruction. There's no difference in survival and recurrence. Okay. The goal of reconstruction is to improve well-being and quality of life for women undergoing mastectomy for breast cancer. Okay. So these would be the recommendations for breast reconstruction. Okay, just both all are grade C evidences, so there's no grade A or B evidence. Okay. That's the difference between breast conservation and your radical mastectomy. Okay. Then, if your chemotherapy is needed, either before surgery as a tumor reduction procedure, so that the tumor will shrink prior to surgery. So you can see how your cancer will respond to the tumor. You could also do it post-surgery as you treat cancer and use carefully measured and controlled high-energy X-rays. So you will do your radiotherapy. So these are the recommendations. If there are more 4 lymph nodes, there's positive margin, you do your adjuvant radiotherapy. It's offered if you have 1 to 3 lymph nodes, if you have negative disease but high risk factors. Okay. Grade A, post breast conservation radiotherapy. All patients with post breast conserving surgery should have radiotherapy. All right. I think that's the end of my slides. These are just your algorithms for your breast cancer. And of course, follow up. So every 3 months for the first year, then every 6 months for 5 years, then annual thereafter. And of course, that is to look at recurrence. Okay. And lastly, you have the male breast. Okay. Gynecomastia is a common condition. Some may be physiologic, seen at puberty, or pathologic, seen with cirrhosis, cancers, and the like. So it can be both unilateral and bilateral, which usually presents as diffuse enlargement or defined mass. And usually these would be indicators of hyperestrogenism. Of course, neoplasia should be considered. Okay. Although very rare, female to male ratio is 100:1, pathology is similar to the female breast. Other than the skin involvement would be more frequent because it's more evident in the males because they have less fat tissue. All right. So that's the end of our breast lecture. Any questions?
No, doctor.
Okay. Can you see the next slide? This Can we have a 5-minute break? I'll just catch my breath. I'll just I'll start in 5 minutes. Lecture would be on gestational trophoblastic disease. Okay. So this is a term used to encompass a group of tumors, which is typified by abnormal trophoblastic proliferation. Usually it's detected because there's marked increase in your beta HCG. So this is a table which shows your classification of your GTD as seen in your WHO, as classified by your WHO. So your molar pregnancies would be your hydatidiform mole, whether complete or partial, invasive mole, trophoblastic tumors such as your choriocarcinoma, placental site trophoblastic tumor, and your epithelioid trophoblastic tumor. Okay. So you have GTN, or this would be your malignant forms of GTD, which is comprised of your invasive mole, choriocarcinoma, your PSTT or your placental site trophoblastic tumor, your epithelioid trophoblastic tumor, and the file. So this commonly follows your H mole, but some of these malignant forms of GTN can follow a normal pregnancy, an abortion, etc. Diagnosis remains to be clinical and HCG as the main laboratory indicator for your highly deformed mole. Treatment would be chemotherapy. So this is an example of a gross picture and an histologic picture of your highly deformed mole. So you will see trophoblast proliferation of villi with stromal edema. So you have your complete or partial, which would have different risks for comorbidities, which would have different need for post-evacuation therapy. If it's complete, it's a villi with mass of clear vesicles. If it is partial, it's a focal and less advanced and would have fetal tissue that's evident. This would be your partial and your complete mole as it is differentiated according to cardiotype. So you have your 46XX for your complete mole and your triploid for your partial mole, either an triple X or an XXY. How it clinically presents and the pathology involved. Epidemiology, you would see that it's common in Asian countries, 10 times higher than what is found in Europe and North America. So we Asians would be more knowledgeable in how to handle this disease. For example, in India, it's 1 in every 400 pregnancies. Affects extremes of age and is affected by any prior hydatidiform mole. If it's complete, it's a 0.9 risk, partial 0.3. And if you have had 2 previous complete moles, it could be as high as 20%. So what's the pathophysiology? So you have your maternal chromosome inactivation. This is for your complete mole. Then you have your sperm, which is a 23X. And your paternal chromosome duplicates. Thereby, your 23X becomes a 46XX. So it becomes duplicate and it proliferates. It will produce your 46XX. Okay. It's partial. You have a 23Y and a 23X, resulting in a dispermy and a diandry. So you would have a triploid cells as an outcome. So you would either a 69XXY and a 69XXY with maternal and paternal chromosomes. Okay. So here, there's just paternal chromosome duplication. So for partial, you have maternal and paternal chromosomes. Okay. So why is it important? So especially in twin pregnancy. So one would have normal fetus paired with a diploid molar pregnancy. And your differentials could be the following: a placental mesenchymal dysplasia, a subchorionic hematoma, or a chorioangioma. So this may be distinguished by a chorionic villus sampling, amniocentesis, or fetal cord blood sampling coupled with fetal karyotyping and confirmation. So complications, thyrotoxicosis, preeclampsia, hemorrhage, preterm delivery, and developing subsequent neoplasia. Now, with better prenatal care and universality of ultrasound, diagnosis is often earlier. So most HMOs are treated before complications ensue. And these are the clinical findings. Most common would be amenorrhea, then vaginal bleeding. Would produce anemia, would produce hyperemesis gravidarum because of increased beta-HCG levels, enlarged uterine size because of the proliferation of your trophoblastic villi, softer uterus, decolleting cysts, increased free T4, decreased DHH, preeclampsia, and eclampsia. So by listing the following, you will see that there are a lot of risks involved in hydatid deformol. Okay. Diagnosis would center on serum beta HCG. So this is expected. HCG is elevated above gestational age. So this is hook effect. You can lead to erroneous false negative urine pregnancy test results. And what can you do to make it positive? You do your dilutional test. Dilution, because your assay has only a certain range and your HCG in HMO is very high, you have to dilute it 7 times. Once you dilute it 7 times, at least, you will see that it's detectable by the assay and you will yield a positive result. Okay. This is a classic ultrasound picture of your HMO. So it appears as an echogenic uterine mass that's filling your endometrial cavity and is surrounded by normal myometrium. So you have your numerous anechoic cystic spaces of different sizes and shapes, but without a fetus or amniotic sac. So this is what you call a snowstorm appearance, and your color Doppler will show marked surrounding myometrial vascularity. So you have your absent internal flow, which reflects the avascular villi of complete moles. So for ultrasound, you have a thick multicystic placenta plus a fetus or fetal tissue. So there's a thin septa which can be found within the gestational sac. So affected fetuses usually die in the first trimester. So there could be growth restriction, oligohydramnios, and limb or CNS defects. So what could HMO mimic? Any first trimester bleeding, you think incomplete or misabortion, multifetal pregnancy, or leiomyoma with cystic degeneration. Okay. So you have to do surveillance to monitor as you establish your molar pregnancy. You diagnose immunohistochemical staining with P57 KIP2, or you do your molecular genotyping. Okay, so it can distinguish which among a diploid diandric genome, complete mole, a triploid diandric monogenic genome, a partial mole, or a biparental diploidy or a non-molar aportus. Management. Now that detection is early, deaths are rare. Timely evacuation, deaths are rare. And surveillance for GTN neoplasia decreased in incidence. And we are better at identifying its complications. So these are your preoperative, intraoperative, and post-evacuation recommendations. whether it be a laboratory recommendation or a procedural recommendation or a medicine that should be administered during evacuation. Terminate, termination suction curettage is the preferred treatment. Okay, so you dilate with an osmotic dilator. So this is usually laminaria or a balloon catheter. You anesthetize to establish IV access and make sure blood products are available in case you do encounter hemorrhage. Okay. What is done in your suction curettage? So your cervix is mechanically dilated to preferably allow insertion of a large cannula. Oxytocin is infused. You do your sonography to ensure complete uterine cavity, minimize perforation risk. You do gentle curettage with a sharp curette. Look out for bleeding. If there's bleeding, you may do pelvic embolization, uterine packing, hysterectomy when necessary, and look out for the complications. Post-suction curettage, if it's an Rh-D negative women, you do your anti-D immunoglobulin or your ROGAM, because fetal tissues with a partial mole may include red cells with the D antigen. So long-term prognosis for women with hydatidiform mole is not improved with prophylactic chemotherapy. So routine chemotherapy is not recommended for women with H-mole. So management, you could do your hysterectomy with ovarian preservation. So these are for women who have finished childbearing, completed family size, or have moles with high-risk features. Or women aged 40 to 49 years, because it has been shown that up to 50% will subsequently develop GTM. And of course, removing the uterus markedly reduces this likelihood. You did not remove the tecalotaine cysts. You may do a labor induction or hysterectomy. Is seldom used for molar evacuation because of the propensity to have increased blood loss and raised incidence of persistent trophoblastic cysts. Okay. Important for post-evacuation would be surveillance, and we measure serial beta HCG. Okay. This is to detect persistent or renewed trophoblastic proliferation. Okay. So initial level is obtained within 48 hours. Then it's done thereafter every 1 to 2 weeks. So usually it results within 6 weeks for partial moles, 7 weeks for complete moles. Once it's undetectable, you monitor monthly for another 6 months. Okay. So reliable contraception is imperative so that you do not confuse your beta HCG levels with a new pregnancy. So either you use your combined hormonal contraception, injectional DMTA, or your implant. So IUDs are not recommended unless beta HCG levels are undetectable. So the risk for GTN would be the following. There's increasing or plateauing levels of your beta HCG. Complete moles would have 15 to 20% incidence of malignant sequela compared to a 1 to 5% if partial. Older age, higher than 100,000 beta HCG, uterine size more than 6 weeks, decalutane for more than 6 centimeters, and a slow decline in your beta HCG levels. Okay. So what then is your GTM? So this includes, excuse me. So this group includes invasive mole, cariocarcinoma, placental site, trophoblastic tumor, and epithelioid trophoblastic tumor. So these tumors almost always develop with or after some form of recognized pregnancy. Half would follow hydatidiform mole or tubal pregnancy, and another fourth will develop after a preterm or term pregnancy. So these are histologically distinct but are diagnosed by your persistently elevated serum beta HCG because tissue is infrequently available for study. Okay, so this is a criteria for diagnosis. So as mentioned, plateauing of your beta HCG level. So that's an increase of or decrease of just 10% for 4 measurements during a period of 3 weeks or longer. A rise of serum beta HCG more than 10% during 3 consecutive measurements, or serum beta HCG that remains detectable for 6 months or more, and a histological criteria for choriocarcinoma. So aggressive invasion into the myometrium and propensity to metastasize is a characteristic of your GTM. Most common findings, bleeding associated with uterine subinvolution. So you have your myometrial perforation from trophoblastic growth, which can cause short intraperitoneal hemorrhage. So bleeding after any type of pregnancy should prompt serum beta HCG level measurement. Uterine size is assessed, careful examination would seek lower genital tract metastases, which usually are bluish vascular masses. Okay. Again, baseline serum beta HCG and hemogram are obtained. So you have to look at local disease and metastasis, to look at liver and renal function, sonography, CT scan, brain and APCT or MRI imaging. PET scan, CSF level determination of your beta HCG are used to identify metastasis. If no extrauterine disease is found, you could either do a second curettage or hysterectomy. Okay. Beta HCG is measured every 2 weeks until 3 consecutive until it lies in an undetectable range. So levels are subsequently repeated after 6 months. So if it persists after curettage or hysterectomy, or if initial extrauterine disease is found, patients undergo staging and chemotherapy is instituted. Okay. So this would be your W8 FIGO classification, staging, and diagnostic scoring system for your GTM. So it is graded according to age, antecedent pregnancy, interval, pre-treatment serum beta HCG, largest tumor, and the like. So it's graded 0, 1, 2, and 4, and it will the total number, okay, low risk if it's 0 to 6, and more than 7 would be high risk. Okay. So what is invasive mole and chorioadenoma destruens? So these are almost all invasive moles which arise from partial and complete moles. So there's extensive tissue invasion by trophoblast and whole villi. So trophoblastic cells penetrate deep into the myometrium and sometimes involve the peritoneum, adjacent parametrium, or vaginal wall. And there's less prone to metastasize. Okay. Gestational choriocarcinoma. So this is the most common trophoblastic neoplasm to follow a term pregnancy or a miscarriage. Only a fourth of cases would follow a molar gestation. Cells which are reminiscent of early cytotrophoblast and syncytial trophoblast, however, contains no villi. So rapidly growing tumor which invades both myometrium and blood vessels that creates hemorrhage and necrosis. This may spread outward and become visible on the uterine surface as dark irregular nodules. So there could be metastasis, which is blood-borne, to the lungs and the vagina. And this is closely associated with decalutane cysts. So next would be your placental site trophoblastic tumor. It's relatively uncommon, which arises from your intermediate trophoblasts at the placental site. So this would be moderately elevated beta-HCG levels and would have variant forms. This is not responsive to chemotherapy. That's why hysterectomy is the preferred treatment. So for higher risk, you do your adjuvant multi-drug therapy is also an option. Okay, for epithelioid, trophoblastic tumor, so this rare tumor develops from chorionic type intermediate trophoblast. So the uterus is mainly involved in speeding, but low HCG levels are typical findings. So hysterectomy is also the first line because this tumor is resistant to chemotherapy. Metastasis is common and you use your combination chemotherapy to reduce the incidence of metastasis. Okay. For GTN, chemotherapy is the primary treatment. So some, if it's without extrauterine disease, you could do your second uterine evacuation as an adjuvant therapeutic option. Okay. Suction curettage may be infrequently be needed so that you resolve bleeding and remove a substantial amount of retained molar tissue. So hysterectomy can either be primary or adjuvant. Okay, regimens. It could be single agent. Most common would be your methotrexate, since methotrexate is less toxic than your actinomycin. You could also use your combination chemotherapy for high-risk disease, and cure rates are reported to be as high at 90%. Most common regimen would be your EMACO. So this would include your etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. So adjuvant surgical and radiotherapy also may be employed. To do surveillance is important because death frequently is caused from the hemorrhage from metastatic sites, respiratory failure, sepsis, multi-organ failure due to widespread chemo-resistant disease. So if it's low or high risk, once your serum beta-HCG levels are undetectable, surveillance is continued for at least a year. Of course, avoid pregnancy. So aside from confusing it with your beta-HCG levels, of course, there are teratogenic effects of your chemotherapy to the fetus. Okay. And there's also a term, quiescent HCG. So there's no evidence of metastasis and will be found to have very low beta-HCG levels that plateau. You only need to observe. So for subsequent pregnancy for patients with GTN, you have your women with prior HMOL generally do not have impaired fertility. So they will get pregnant again. So 3% will have a risk for developing trophoblastic disease in a subsequent pregnancy. So sonographic evaluation is recommended in early pregnancy. So women with GTN, so who have successfully completed chemotherapy are advised to delay pregnancy for 1 year. This is because there could be a relapse or there could be persistence of methotrexate in the system. With the prior HMOL or GTN treatment, placenta or products of conception should be sent for evaluation at delivery, even if patient did not have symptoms of HMOL. And your serum beta HCG should be measured 6 weeks postpartum. Okay, I think that's my last slide. Any questions? Could you open your cameras? Let us please Ashley document and send to my Viber, please.